Well, good evening, everyone. It's a very rainy Wednesday evening, so we thank you so much for joining us today. June is Cataracts Awareness Month, and today we are going to uncover the truth about diabetes and cataracts. We have two experts in their fields who really need no introductions, but I will introduce them nonetheless. Dr. Joel David Teelucksingh is a consultant in internal medicine, endocrinology, and diabetes at San Fernando Teaching Hospital. He's a UWI graduate and has postgraduate training in the United Kingdom. He has a master's in public health. He's a scientific advisor to the Diabetes Association of Trinidad and Tobago. He is passionate about public health and education. He's also the host of the weekly live television show on CNC3 Ask the Doctor. And he also does a weekly column in the Trinidad Guardian. Next, we have Dr. Ronnie Bhola, leading vitreoretinal surgeon in Trinidad and Tobago and CEO at Trinidad Eye Hospital, who has transformed eye care throughout the country and region over the last decade. He is an MBBS graduate of the University of the West Indies and completed advanced subspecialty training in the UK. He is a fellow of the Royal College of Surgeons, with his career spanning both the public and private sector. In 2024, he was awarded the Hummingbird Gold Medal for his outstanding contributions to medicine in Trinidad and Tobago. He is an active member of both the Ophthalmological Society of the West Indies and the Ophthalmological Society of Trinidad and Tobago, with dedication to advancing eye care, research, and education in his field. So welcome, doctors. Glad to have you both here this evening. And we're
Thank
going
you.
to get right into it. So, Dr. Bhola, what is a cataract and how does it impact your vision?
So I was trying to get my model here. So if you look at this model, this here is the back of the eye where the optic nerve is. This is the film in the eye called the retina. And this here is where the lens is in the eye. So you can see that if anything happens to this lens, the light that's supposed to come through the front of the eye, which through this little peephole, the pupil, really has difficulty getting to the retina to form the image. So this is what happens in cataract. This lens that is normally nice and crystal clear becomes cloudy over time, and as a result, it's like looking through a dirty window because this lens needs cleaning.
And is this change in lens just because of aging, or as we're speaking about diabetes, people with diabetes are at a higher risk of developing cataracts?
So the most common cause of cataract is aging. Over 90% of the cataracts we see is due to aging. But cataracts could be caused by many things. And we like to classify cataracts into congenital cataracts or acquired cataracts, which means the congenital ones we see in the babies or in the young children. But the acquired ones, they happen because of either something happening throughout your life or the aging process. And in terms of things that could happen, we like to split that into ocular causes, things that could happen in the eye to cause cataract, or things that happening in the body that might cause cataract. And Joel, I know, is the man that knows all those things that happen in the body, and he would be telling us a little bit about that. But the main one that we see in our clinics is diabetes as a systemic cause of cataract formation. In terms of ocular, things like trauma is one we see pretty commonly, and inflammation or infection in the eye could also cause it. Systemically, sometimes we see drugs causing it, like steroids, and I know Dr. Teelucksingh might want to tell us all the things that steroids cause with the body, and cataract is just one of them, you know.
Okay, thank you. And Dr. Teelucksingh, moving on to your question, which is the next part of it. We hear about diabetes and type 1 and type 2 and HbA1c and all these terminologies being thrown around. So can you tell us what is diabetes and kind of explain to us all of these different things?
Thank you very much for that warm welcome, Pri. And indeed, it is an honor to be a part of this distinguished panel. I want to congratulate the entire team at the Trinidad Eye Hospital for having the foresight to bring these separate pandemics onto the front burner. Because diabetes is a pandemic, it's a global surge, and cataracts, as we heard from Dr. Bhola, has exploded. In fact, it's probably the commonest surgical procedure. Diabetes is one of the most frightening scourges in the world. It has been estimated there are about 550 million people with diabetes. And what is scary is that 1 in 2 persons would not be aware of the diagnosis. It's a leading cause of blindness in working aged persons, a leading cause for end-stage kidney damage. You are 2 to 3 times more likely to have a heart attack and stroke if you're a person with diabetes. And it's a leading cause of non-traumatic loss of limbs. In San Fernando, as I say, at the hospital, we actually have a ward for persons with foot ulcers, infections, and amputations due to diabetes. There's a ward dedicated to this dreaded complication. Now, it's marked by high blood sugar. And as you mentioned, most persons may have type 2 diabetes. So the hallmark is insulin resistance. So perhaps it may be driven by fat around the tummy. There is a certain level of insulin being produced by the pancreas. The body is not able to utilize it effectively, leading to a rise in blood sugar. So insulin is the hormone, or it's the key that allows cells to utilize sugar effectively. In type 1 diabetes, about 10% of the population, usually younger, slender persons, there is an insulin deficiency. There is a destruction in the cells of the pancreas. So there is a lack of insulin, and those individuals need injections of insulin. There are some gray zones in persons who don't fit into these categories of type 1 and type 2. There may be secondary causes, as Ronnie mentioned. Long-term use of steroids can actually cause diabetes, as well as impacting the lens of the eyes. It may raise your blood pressure. It may lower your resistance to infection. It may increase the body weight. So there are secondary reasons. There are some genetic syndromes which may cause your levels to rise, your blood sugar levels to rise. But most persons are battling this surge in type 2 diabetes, which is driven, of course, by another pandemic, that of obesity.
Right. Well, that's a lot. Thank you so much for answering that. But you mentioned that diabetes is the leading cause of blindness. So how does diabetes affect the eye in relation to cataract formation?
That's an excellent question, because being a multi-organ problem, that's why we speak so much about maintaining your hemoglobin A1c level, perhaps 6.5 to 7%. And for the sake of our viewers, that's your average sugar for the preceding 3 months. So when you check your finger stick, it tells you what your sugar is at that point in time in a doctor's office or at home. The hemoglobin A1c looks at some level of variability in your sugar, the average sugar for the preceding 3 months. And getting to that target is going to reduce the chance for some of the complications affecting the eyes, including changes to the retina. There may be a problem called glaucoma that we could speak about on a separate time. High blood sugar in the lens will convert glucose. Glucose is converted by an enzyme to a substance called sorbitol. And this compound causes swelling to the lens, and eventually there is degeneration and damage to those fibers in the lens. So leading to the cloudiness and the complications that many of the patients experience at a younger age. So it involves a conversion of blood sugar to the compound sorbitol and then changes to the lens.
And is there a specific stage in diabetics where these cataract symptoms start to appear?
That may be variable. In persons who have diabetes, especially if your sugars are poorly controlled, you're having erratic levels of hemoglobin A1c for years. You may find that, of course, you're at a risk for damage to the retina. We spoke about some of the changes to blood vessels in their kidneys and in the legs. So there are large and small blood vessels. It's certainly accelerated in persons with very high blood sugars. It's variable, but that's why we say that in type 2 diabetes, from the point of diagnosis, you should be screened by an ophthalmologist. That's a surgeon who specializes in complications and indeed some of the surgical aspects of the diabetic eye. It's been found 20% of persons may have changes to their eye at diagnosis with type 2 diabetes. Type 1, perhaps after about 15 years, 90% of those individuals may have changes to the back of the eyes. It varies, as I said, and that's why it's important to be screened regularly. The watchword is prevention.
I like that. And Dr. Bhola, as Dr. Teelucksingh mentioned that we should get patients screened regularly, how regular do you recommend that diabetic patients should have eye exams?
If somebody is newly diagnosed and we see them, because Dr. Teelucksingh usually refers them straight away to get their eyes checked. And once we see them and we do that initial screen, if we find that they have no diabetic eye disease at that point, we usually give them a routine 1-year follow-up at that point. However, if we see little changes, what we call background diabetic retinopathy, because we don't know how it's progressed, from the time that they started to have diabetes, we might see them a little sooner. So we might see them 3 to 6 months after. But once we think they're pretty stable over time, then we extend those visits, those appointments. So initially, we might see patients a little bit of a shorter time frame until we get the confidence that they're pretty stable, and then we extend it out. But generally, if you have no diabetic eye problems that we're picking up on screening, then we usually give you a 1-year follow-up. And that's the kind of regular thing for a diabetic. A non-diabetic, that we usually see those patients once every 2 years. And they normally go to their optometrist because they're not diabetic. We don't expect them to have any untoward disease on the retina. And the optometrist and other healthcare professionals could screen and look for disease. And once they see anything abnormal, then they usually send the patients for us to do a more comprehensive, thorough examination.
Right. And then when we see patients with cataracts, the next option would be treatment. So, we hear about these patients who put honey in their eyes because it will help the cataracts to regress, and the bush medicine, because Trinidad has a culture of using a lot of bush medicine. What would be your recommendation for moving forward?
Yeah, we haven't found any good way other than surgical so far to really cause cataracts to regress, which is as they developed already, to try to get them to go away, or to keep them from not developing. So there isn't any medical treatment or drops that we could use or anything else. For instance, the herb line. So the truth is we don't know for sure, but medicine suggests that these treatments are unlikely to work for cataracts. The main thing is, if you diagnose with cataracts, you shouldn't be worried and try all sorts of things, because the treatment is amazing. It's one of the surgeries of the century. It really transforms vision, but also transforms lives. So if you have a cataract, you come in, we get the surgery done 10, 20 minutes, and voila, you're back to 19-year-old vision, So don't be afraid, come in and get your surgeries done.
And Dr. Teelucksingh, there are patients who identify as being pre-diabetic or borderline diabetic. Do they face the same or similar risks of developing cataracts?
That's an excellent question, Pri, because there is exploding information that those persons who have changes to their blood sugar control. So if you may allow me, For persons who are on the threshold of becoming a diabetic or pre-diabetes, maybe a fasting blood sugar level of 100 to 125 milligrams per deciliter, 2 hours after a glucose drink or a random check on their blood sugar, 140 to 199 milligrams per deciliter. There's trouble brewing. There are problems occurring at the level of the pancreas. And this concept of insulin resistance is brewing. So there is an issue occurring. And there's burgeoning scientific evidence that there may be changes in some of those smaller vessels, not just in the eyes, but to the nerves and the kidneys. So it's a call to arms. The watchword once more is prevention, and those individuals may find that their blood sugar level could be reversed to normal. There is a concept of reversibility when we talk about diabetes, and that can also be extended to pre-diabetes. Those persons who are just on that threshold with intensive lifestyle changes, healthy diet, in which you are avoiding white flour, white rice, white sugar. You're having one rich in fruits, vegetables, nuts, peas and beans, low fat and low salt, and regular physical activity for 30 to 60 minutes of most days in the week, whether you're walking, running, jogging, biking, or in the case of you, Zumba. So 30 to 60 minutes most days in the week to actually help your blood sugar. And that can reverse someone with pre-diabetes to a normal glycemic state, or what we say, normal glucose control. So there may be changes which could occur. Perhaps, of course, as your blood sugar is rising, you will find that this will expedite the development of the cataract. Because as we said, blood sugar is converted to this compound called sorbitol that subsequently will affect the lens. So it's a call to arms, and it is indeed an opportunity for persons to pay attention to lifestyle changes at that point. Diet as well as exercise, weight loss, monitoring not just your blood sugar, but your blood pressure and cholesterol.
And it's a little bit hard because we like doubles.
Well, we come from a culture like this, which unfortunately is built around food and enjoyment, and that's all part of life, perhaps in moderation.
I like that.
I just wanted to ask Dr. Teelucksingh a question. We see a sort of mushrooming now of the amount of patients who have diabetes in the clinic. I'm wondering why we have this pandemic or epidemic of diabetes. What's your thoughts? Maybe we could just say why we think it's happening so much in Trinidad, because we see in these patients and in our clinics.
That is an excellent question, Ron. And I think it is steeped in the fact that we have changed our lifestyles to one which is more westernized in terms of, as part of this rat race, we're getting less sleep, we are more stressed, we're working, we've substituted muscles for machines, we've started buying food instead of having food which perhaps would have been grown in a backyard garden. Of course, we are now also paying more attention to diagnosing some of these chronic problems. But I believe it is the fact that we are seeing this surge in increasing fat around the tummy or abdominal obesity. You have to think of that as a driver. Fat cells are not just storage depots that you could balance your child or your grandchild, and it's a sign of affluence, and you're very pleased about it all. Fat cells are angry and exploding. These are very active cells that produce inflammatory substances. They produce hormones, which are chemicals that change your blood sugar, your blood pressure, cholesterol, and increase your risk for having a heart attack or a stroke. And think of obesity as the driver. When you look into the rearview mirror, you're seeing diabetes and some of the deleterious effects, some of these chronic, non-communicable diseases that has become very much onto the forefront. I think that is the driver. That is actually the reason that our lifestyles have changed over the last 2 to 3 decades. And unfortunately, not for the better. We have adopted a westernized, perhaps more affluent lifestyle. And so if I may add, it is not so easy to access healthy food. these are more expensive. Someone who is working and balancing 2 and 3 jobs, a single mother, may find that as a result of socio-economic problems, she has to buy the cheapest and unfortunately calorie-dense foods for her children. She's tired at the end of the day. Children, we drive them from primary school about the value of examinations. They are no longer playing. Perhaps some of the areas don't have green spaces. We have surges in crime. So it's a complex genetic, environmental, social-cultural, psychological phenomenon that is driving the obesity pandemic and subsequently the deleterious consequences.
Thank you.
And-
Thank you. Excellent.
And do you think it's more prevalent in females?
Diabetes.
Now,
that is an interesting question because we certainly would say that if you have a family history, that you're more prone, especially when we're talking about type 2 diabetes. We know that women in general are interestingly more likely to be obese than men in places like the West Indies. They've actually studied it. And the prevalence of obesity is higher in women in parts of the world. And I believe that is why you might see some of these chronic NCDs, such as diabetes and hypertension, being noticed. They're also more likely to seek medical care, interestingly. So they're also more likely to be diagnosed with diabetes at an earlier age. In fact, women are the unsung heroes and heads of the household. We know this. They are more likely to encourage family members to access care, but they also have a higher prevalence of obesity in places like Trinidad and Tobago. And thus, this drives all of these aspects. The term is the metabolic syndrome, driven by fat around the tummy and distortions or disruptions in the metabolic milieu or environment, is causing your blood sugar, your blood pressure, cholesterol, and inflammation. It brings us back to that term, inflammation, that causes all of these negative consequences. So it may be the fact that they are more likely to seek care, they're more likely to access blood investigations. They also drive the rest of the household to do so, but also they are more likely to be obese.
thank you.
And have some of the effects, if I may add, Pri.
Sure.
Polycystic ovary syndrome is also a risk factor, which is a commonest hormonal abnormality in a woman of a reproductive age. They have problems like acne, hair growth, problems with periods or fertility. But lurking in that background is insulin resistance, that darkening to the neck or the knuckles, the armpit. The Latin term is acanthosis nigricans, but they are more likely to have type 2 diabetes. Women, when they become pregnant, may be at a risk too of insulin resistance due to hormonal changes. And 50% of those women who develop gestational diabetes are more likely to become type 2 diabetic. If they have big babies, if they've had a history of miscarriages, and these also create an environment of an enhanced risk in that particular gene.
Such important points. Okay, so Dr. Bhola, going back to cataracts, is it riskier for a diabetic patient to have cataract surgery than a non-diabetic patient?
Yeah. Before I answer that one, I like Dr. Teelucksingh's comment, because just to add to what he said there, the patients we see, the female patient seems to have more advanced diabetic disease when we see the eyes at the females compared to the male diabetic. And I'm sure you see that in the surgery department, a lot more female diabetics coming through to have retinal detachment surgery, vitreous hemorrhage, than male diabetics. And that's really an interesting thing, as he mentioned it there. I mean, it never really dawned on me that we were seeing
Might be
this.
worth a local study.
Yeah.
Might be worth a local study, Ron.
Yeah, I really like these forums because we start to brainstorm on things we could really look at in the clinic. So that might be something we could look at. What the question you asked is whether diabetics are more likely to develop cataract, right? Or what
No, sorry, we're talking about surgery, so we're asking if it's riskier surgery for diabetics. versus
right.
non-diabetics?
Right. Not by much. That's the truth. Because cataract surgery in diabetics or non-diabetics has really progressed on from the older days over the last 20, 30 years to being a really almost non-traumatic type of surgery because we make these really tiny incisions. We're able to really just suction the lens and slip the artificial lens in without causing much change to the natural environment in the eye. And that really means that the eye is not subjected to a lot of inflammatory changes post cataract surgery. And therefore, it doesn't really cause harm to the eye. The main problem with the diabetics is their control before surgery and the length of time that they were diabetic affects other parts of the eye. And when we do even a minor procedure like a cataract, it could tip them over because they were already close to the point where they were going to develop a problem. And they get the retinopathy, the maculopathy seems to increase after the surgery. But that thing was brewing for quite a long time with the up and down blood sugar and the length of time that they have the diabetes. And now they link it to the cataract surgery, but it's really not so much related to the cataract surgery. It's more related to that underlying disease that was ongoing. And they might have other risk factors that weren't looked at or managed well before the surgery. So I really like the question because we really need to optimize the patients before the surgery. And we really need to work with our medical colleagues to do that, get their blood sugar under as good control as possible, blood pressure, make sure they're really trying their best to live a healthier lifestyle and then do the surgery. So then you're less likely to have problems after the surgery with the other parts of the eye that might be affected by the diabetes.
Thank you. And Dr. Teelucksingh, in your opinion, are there any special precautions that diabetic patients should be taking when they are going ahead with surgery?
It's a fascinating question because most of our viewers would be aware that if you're a person with diabetes, you have an increased susceptibility to infection, particularly if your blood sugar is poorly controlled. So, of course, there may be some attendant risks, like some persons are hypertensive. You'd want to ensure that you are adhering to your medications. Of course, we spoke about the value of lifestyle changes, your diet as well as exercise. Perhaps get a hemoglobin A1C pre-surgery or before the operation is actually contemplated, trying to get a hemoglobin A1C of 6.5 to 7%. It's going to not just lower your chance for infection, but also some of the negative effects of diabetes on the eye. So although we are honing in on the cataract risk, we mentioned that there are maybe some sight-threatening problems associated with these swings, or glycemic variability is the medical term, these swings in blood sugar. So you're ensuring that you're adhering to healthy lifestyles, listening to your ophthalmologist as well as your family care doctor, your endocrinologist, to ensure that you are in a good place, that you're optimally prepared for this very basic surgical procedure. But blood sugar, blood pressure, you're stopping smoking if you do so. Some of the persons may find that in very hot, dusty environments, they may gain from using properly tested shades by the ultraviolet tested shades to protect the eyes. That may also be useful even before surgery.
And we are nearing close to the end of tonight's session, but what do you think patients can do to reduce the risk of cataracts being formed?
Once more, brilliant question. And as Ronnie mentioned, the commonest reason for having a cataract is the fact that you're growing older. And of course, we don't want to expedite this process by having very high blood sugar levels. So ensuring that your blood sugar level is under control. We mentioned about some of the issues such as smoking, protection of the eyes, you're wearing shades if you're in hot, dusty settings. And also, the watchword is prevention once more, Pri. ensuring that you maintain healthy lifestyles, adhere to medications, and regular testing. So if I may add, the eyes are the windows to the soul. And there is some onus, some burden of responsibility that must be placed on the shoulders of our patients. Look after yourselves so that we won't have to.
I like that. I wrote down all of your watchwords, by the way, so we can share them after. So I guess closing comments, Dr. Bhola, we could start with you.
Yeah, I found this very exciting and interesting, this discussion we've been having. And I just want to say a couple of things. One is choice. You really have a choice when you sit to eat. You could either choose something extremely tasty or something that may not be as tasty but a little bit healthier. And making the choice is really, really important for all of us, not only diabetics, really all of us, because we all want to have a long life as possible, but also a high quality life. And to have that, you have to be moving, keep your body moving as active as you could be, but also making this choice on your foods and switching from making choice on taste only and really trying to do go for the healthier options. So one is choice. The other thing that we have to mention, and Dr. Teelucksingh touched on it, is that we may want to make the lifestyle choice of a healthy option, but it's out of reach for the pocket. So we have to lobby on behalf of people who want to make these healthy choices, and that's what Dr. Teelucksingh does every week, and that's what we're trying to do here. And we really need to impress on the decision makers, like corporate TNT, government, everybody, because this is everybody's problem. If we don't get control of this epidemic, it's going to produce a serious financial burden on the healthcare system, which we've seen already, and is going to explode. So it is in our interest to get grips of this problem. And we really need to be able to get the cost of healthy food somewhere close to the cost of the unhealthy one, so that people who want to make the choice could access it. And we have to do our part too, as the doctors, to lobby for that change to happen. That's probably my final
Thank you,
words.
Dr. Bhola. And Dr. Teelucksingh, your closing comments?
Those were certainly some pearls of wisdom from you, Ron. And I want to say a special thank you to the Trinidad Eye Hospital for blazing a trail. Really, I've followed your philanthropy in terms of not just surgeries, but also your excellent work at the Diabetes Association of Trinidad and Tobago and the screening that you continue to offer for our persons with diabetes. I wish to congratulate and thank you. And so some of these complex medical problems that we've mentioned, we've just scratched the surface, but it's important that we explore some of the underlying reasons, because we need to address this in childhood. The problems of increasing weight and the deleterious effects don't just start in persons over 40. We are seeing this in children, and it's almost like a car crash in slow motion, that from the time you start seeing them adopt unhealthy lifestyles that they've learned from their parents or grandparents, their complications are going to happen at an earlier age. We're seeing type 2 diabetes in primary and secondary school aged children. So it stands to follow that the effects on the eyes, the kidneys, the nerves, and the blood vessels will occur at an earlier age. The watchword continues to be prevention pre, and thank you once more. So I look forward to having your team on Ask the Doctor on a Thursday night at 8:30 in the future. It has been an honor, a privilege to be a part of this symposium. Thank you once more.
Well, thank you, Dr. Teelucksingh. Thank you, Dr. Bhola. And just a reminder to the general public, the watchwords were moderation, precaution, prevention. So please take this information, stay ahead of the game, get your eyes checked, get your general health checked, and stay healthy. So I will close off for tonight. Thank you again for joining. Have a good night, everyone.